All right. Good evening, friends. Thank you so much on joining on this Tuesday for clinical reasoning. Actually, it's not clinical reasoning, it's just routine VMR, but it feels like clinical reasoning VMR when I'm with Dr. Singh. So yes, welcome to this VMR. Today, we are fortunate to have wonderful case presenter, Dr. Black. We have seen him present the cases on VMR before as well, very thorough and comprehensive cases. So I'm already looking forward to so much learning. So thanks, Dr. Black, for presenting the case today. We have Patricia, who is helping with describing today, and Kushal, who is helping with the teaching points. So thank you for that. And thanks to everybody who has joined at this time. And let's see how it goes. So Dr. Singh, how has been your day going so far? All good?
Oh, it's been absolutely fabulous. I was just talking to you in the back room about letters, and within a week's time, you probably remember this 2 years ago, application season, or for like Madalena a year ago, how daunting task it was. So just waiting next Wednesday, I believe it is. It starts opening, and we will see the flow of applicants. But good luck to all our CPS viewers in your journey through the application season this year. Back to you, Kirtan.
Perfect. So, Dr. Black, whenever you are ready, you can introduce yourself and then maybe you can get started with the first eloquent.
Okay. Hello, everybody. I'm John Black. I'm an internist and one of the Clinical Problem Solvers Academy members. We'll be sharing a case today with Krishan and Ravi. So coming from LA, I think Chicago and New York. So let me give you the first aliquot. So we have a 40-year-old gentleman. He doesn't have any known prior past medical history, except he'd been told he had high blood pressure in the past, but hadn't had regular follow-up for it. So he's coming in because he went for a pre-employment, physical check, and he was referred to the emergency department because of high blood pressure. So I'll give you the option. I'll pick your brain. Do you want me to stop there and talk about your approach to that, or give you the HPI?
I think you are right, John, that it's a good place to stop and see how we can approach this seemingly common problem. Thank you. Yeah, maybe I can take a first stab at it and then I will ask Dr. Singh his ideas. So yeah, this is pretty common in such a scenario in today's world that many times people go for pre-employment screening and they find that, oh, their A1C is high, or maybe their EKG is showing some abnormal findings, or maybe their TSH is high. And the critical question is that if they have been asymptomatic all this time, then you really don't know when did the problem actually start. So if you don't know the problem, it's hard to find the answer to that. So for example, in this case, we know that we have a middle-aged gentleman who went for screening and they found hypertension. But should we approach this problem as a case of an acute onset hypertension in a middle-aged gentleman, or should we say it is a chronic run-of-the-mill hypertension? Because both the problems require different approaches and different frameworks. So first thing is to get back to the patient and ask them that, hey, have you been told by anybody that you have high blood pressure? If they say yes, then it becomes easy for us. We can just connect the dots that when was the last time you were being told that you have hypertension? And do you know if what was the reading at that time? Like what was the average blood pressure measurements at that time and how it is now, you can compare. Let's say if the patient says that, no, he has been healthy all his life, and this is the first time somebody told him, then our job becomes more tricky because now we have to start looking for possible signs and symptoms which could cause the hypertension and also the things which could be consequence of the high blood pressure. So we can ask the person that, okay, do you smoke? Do you drink alcohol? Some of the common risk factors. Do you have family history of hypertension? Is the person obese or not? Like all the common things of metabolic syndrome. And then we ask about the symptoms that, okay, do you have headaches once in a while? Do you get chest pain, shortness of breath, all the routine things? But the truth is that in about 80% of the people who have hypertension, they do not have any symptoms, like absolutely zero. So sometimes getting a thorough review of systems may not be enough for you. And then you have to start wondering that, do I need to look for any end organ damage, and which can give me some clues? So some people say that anybody who comes in the clinic and who has new onset or even old hypertension for the first time, you need at least screening EKG, and then you can see for any evidence of end organ damage on EKG and then take it from there. So that's the first thing, that is it chronic? Is it acute? Is it symptomatic? It is asymptomatic? And then we can dig deep into what could be causing it. So, Dr. Singh, I'm curious to hear your thoughts that what do you do for such kind of scenarios?
Well, I think what you just went through is just wonderful regarding high blood pressure. High blood pressure is a very modifiable risk factor if you think about it. As a nation, we're doing really pretty poor in that we've only achieved target blood pressures in probably 50% of the population. And as you age, you can say when you get to the age above 55, that 90% of people will have developed some sort of high blood pressure. And what's interesting, we've now given the diagnosis of high blood pressure to a large segment of the population since we decreased the target or the definition from 140 over 90 to 130 over 80. So it immediately caught or casted a wider net for people to be diagnosed as having high blood pressure. And it really does impact socioeconomics, I guess, also the cost of medicine, if you think about it, because the downstream effects of high blood pressure, namely cardiovascular disease, renal disease, ocular disease, and so on, not to mention later on in life, the cognitive effects of high blood pressure. So this is, if now the second thing I'm going to talk about. So generally, high blood pressure we're talking about, but John is presenting a patient that is being referred from a screening for high blood pressure. So you have to anticipate that there's something going on. Either this is not just asymptomatic uncontrolled hypertension, but symptomatic, or what was known as malignant hypertension or hypertensive emergency. So I'm anticipating something else along with this high blood pressure. But you also have to think about high blood pressure plus AMS, high blood pressure plus chest pain, high blood pressure, back pain. So there's certain symptoms that can travel with this and can end up causing the high blood pressure, or the high blood pressure could be causing that phenomena. So high blood pressure, back pain, aortic dissection, high blood pressure, chest pain could cause a STEMI in some cases, or a type 2 MI, or what we call MINOCA. But a few things that kind of troubling me at this moment. But I think high blood pressure is one of those things where you would immediately treat. So this is where we would flip over into management reasoning. What will be the best course of action? And you, as you well know, studies suggest don't give IV meds to somebody with high blood pressure in the hospital unless they're symptomatic. So give them oral medications. You avoid those wild swings in the blood pressure, and you can get a steady state of blood pressure, or get them to target goal blood pressure more effectively with oral medication. So we're always recommending or teaching that in the hospital, because what is a favorite antihypertensive treatment for learners, IV hydralazine is a very popular one because it's very quick and can get the blood pressure down, but it leads to a lot of wild swings in blood pressure, so it's not the drug of choice. But anything else, Kirtan, before we swing the mic back to John?
No, I agree with you, Dr. Singh. It's very important to focus on management as well. So let's see what John has in store for us.
Cool, great discussion. So I go in to see him, or it's in the evening. I walk into, and he's pretty clear that he wouldn't be in the emergency department if they hadn't told him to be there. So you ask him, just kind of probe him for, is anything bothering you? And he does share that he's had several weeks of a non-productive cough. He has had also several weeks of shortness of breath on exertion. He can still function and do activities around the house, but he can't really do more strenuous things like he normally can. So he's not having any fevers, no systemic symptoms. He's not having any rhinorrhea, sore throat. No one around him has had any illnesses. And I ask him about, has this blood pressure been a problem in the past? He doesn't remember the details, but I open up the electronic record and I see that there's been some prescription in the past from some emergency department providers had given him some HCTZ valsartan in the past, but it hadn't been refilled. Same there was a one-time prescription for clonidine, hadn't been refilled, so hadn't really been regularly taking it. So that's kind of the first pass information that was revealed on the interview. And he turn it back to see if there's anything else you want to add, and then I can give you the histories and the exam.
Perfect. Dr. Singh, maybe you can take the first shot this time.
Sure. The chat is asking a few good questions, but I just want to highlight, Mariana, you definitely asked a really good question. Do we treat high blood pressure in the hospital? To be honest, it is adding a high burden to all of the emergency departments by just sending a patient without symptoms to the emergency room for blood pressure control. Actually, a large amount of the population is out there with high blood pressure and they just don't know it, or they just don't have symptoms until you have a symptom like headache or chest pain, shortness of breath, which brings you to a primary care physician's office or to the emergency room. But no, if you don't have symptoms or you don't have some catastrophic downstream effect because of the blood pressure, you really don't need treatment in the emergency room, but you can start off on oral antihypertensives. So flipping over to management reasoning, I usually will start every patient. So just kind of aside, clonidine was mentioned here. So clonidine is not a very good medication. I usually will start with at least every patient should get one of the ACD or ACE-ARB, calcium channel blocker, diuretic combination. You can have actually all three combinations, and they are very effective. I don't remember the percentage, but they will control a large population of the patient's blood pressures. Beyond that, then you go to the next tier, which would be like aldactone, according to the Pathway 2 trial, is very effective antihypertensive agent. Long-acting nitrates can be there. Hydralazine, lower than that. And then you get all the really strong medications that have side effects like clonidine, and it can cause depression. So you get these depressed hypertensive patients. Labetalol is another one. Minoxidil is another one, devastating side effects. And then the alpha blockers, doxazocin and so on, that can make you syncopal or dizzy as well. But usually you won't start thinking somebody else floated the idea of secondary hypertension until somebody's not or has been put on 4 medications and is still not controlled. In that case, you might start to suspect maybe another cause in such a patient, or your exam might yield something, yield a clue that you could pivot on to maybe make a diagnosis of secondary hypertension. Anything else? But I just want to highlight the clonidine just as a stopgap measure for somebody's blood pressure is not the ideal medication. That's reaching for the bottom tier of the antihypertensives. You should reach to at least the ACD group of antihypertensives.
Perfect. Thank you so much, Dr. Singh. And building on what Dr. Singh has been saying, that in this case, firstly, we want to know that what was the absolute number of the serial blood pressure measurements that we did. For example, in this case, let's say if John tells us that his patient blood pressure is 210 or 120, and now with this several weeks of non-productive cough, shortness of breath, immediately you start wondering if this could be considered as one of the hypertensive emergencies in which you can have heart failure, which is causing pulmonary edema or not. So finding the exact value of blood pressure in this case might be important. The second question would be that this person has been prescribed valsartan and HCTZ. Was there any particular reason that he didn't take that? And secondly, if it was prescribed, was any evaluation done at that time? And this is important because we are talking about a 40-year-old gentleman. Now, we know that with the change in the epidemiology, with the change in the obesity pandemic coming in, the hypertension age of onset has shifted. Like initially, we used to think that how can you have hypertension at the age of 30 or 40? It has to be considered as early onset hypertension. But nowadays, it may not be true. But still, I would want to know that this person is fairly young. So what kind of workup, if any, was done at the time of diagnosis of hypertension? Because that could give us a vital clue. Let's imagine that probably the workup was never done, or even if it was done, we don't have it available. Then we have to start wondering that how can I link it with this non-productive cough? So first things being first, it has been several weeks. It is not something which happened today, so which is a little bit reassuring. The common things being common, we could imagine or assume that maybe this person has high blood pressure for long standing and which caused the increased afterload. And eventually we know that heart cannot sustain that afterload, and either it will undergo hypertrophic cardiomyopathy or it can undergo dilated cardiomyopathy. And then everything will go back in the lungs, and chronic pulmonary edema can give you the non-productive cough as well. This is the simplest and easiest explanation. The second thing could be that maybe the person has long-standing hypertension, but as we know that always the processes which are long-standing, they can flare up once in a while. So maybe there is an acute change, like something happened and that caused the patient to tip over. So like acute flash pulmonary edema, something which is known as CAPE, like sympathetic crashing acute pulmonary edema. So we would like to know that does the person personally believe that maybe his shortness of breath is just a little bit more worse than his baseline or not. So in this case, getting transthoracic echo eventually to make sure that there is no lowering of the ejection fraction or no diastolic dysfunction will be important. The second thing would be getting the labs, because whenever somebody has non-productive cough, we are worried about volume. Now, where can the volume come from? So the most common explanation is pulmonary edema, maybe the heart is failing. But second thing is when the heart fails with the hypertension, often your kidneys are also affected. And we often combine both of these organs involvement as CRS, like cardiorenal syndromes. And there are like many types of cardiorenal syndromes. And the whole idea is that the dysfunction of one of the organs, either heart or kidneys, can impact anything else. So in this person, it's possible that maybe the blood pressure is so high that it eventually affected the kidneys. And since kidneys are not able to filter out excess volume, all that volume is dampening up in the heart and in the lungs. And that's why this person is so short of breath. So I would like to know that how are the kidneys doing? Is the patient making appropriate amount of urine or not? And although there was non-productive cough, eventually you start figuring that was it really non-productive or was there time when there was some blood streaks, then you start wondering that maybe the pulmonary pressures are so high that you are distending the capillaries and you are causing hemoptysis or not. So with this limited piece of information, this is the best we can do. We can try to make sure that we are not missing any complications. So what do you think, Dr. Singh? What should be the next course of action?
I really like that. That was fabulous. So SCAPE is just like what was the other brash? Remember you presented a case of brash? I never forgot it since then. So we discussed it and I did connect the dots, but yeah, so SCAPE definitely is something where you have to act. Patient is coming in dire straits, so you have to act accordingly. It would be ideal to put the patient on CPAP and diuresis and also intravenous nitrates, Tridel along with that as well. I liked the physiology. What you did wonderfully there, masterfully there, was relate the physiology. So what are the organs? If you break it down into its components, what is responsible for blood pressure? You have your vessels, right? So vascular tone. Occasionally, you ask if there's a family history amongst hypertensive patients. There may be, and there could be some abnormal channel issue with the vessels, I guess, which is familial. The other thing then is volume you mentioned, and right there you sort of hit the nail on the head. If you have renal disease, I mean, usually if I elevate my blood pressure, I get really mad. My blood pressure goes up. What my kidneys will do, because ANP, the stretch receptors, will release a hormone, and then that will signal my kidneys to diurese, and my blood pressure can come down. When you have renal disease, you're not able to diurese and release that volume. So that's why a lot of patients with renal disease are unable to regulate their blood pressures. So that's important too. Then next comes the heart. Next comes the brain and neurological symptoms, and then comes the endocrinological organs as well. So any part of that becomes dysfunctional, and blood pressure could just be out of order. But I'm very interested. What do we see commonly? We do see a lot of renal disease. So the blood pressure causes the renal disease, then the renal disease sets up this vicious cycle where the blood pressure gets worse and worse. And then you get other effects, like you said, hypertensive heart disease and so on, and arteriosclerosis. So it's different from atherosclerosis. So you get the thickening of the vessels. So as the vessels are exposed to more and more blood pressure, they become thicker. So they go from pliable, soft vessels to lead pipes, so thick. And that also increases the blood pressure. So you see, it sets up a vicious cycle. So controlling blood pressure is very, very important, because that way you can control a lot of the side effects and a lot of the cost to society of dialysis with renal disease, cardiac symptoms, frequent hospitalizations, and so on. Back to you, John.
Cool. Yeah, great. Just a lot of great pearls in there. One of the ones I really like and I want to highlight is just teasing out whether there's end organ damage and there's hypertensive emergencies. Not always like straightforward on the first pass as you're working your way through. Somebody could have a really high blood pressure and be short of breath from pneumonia causing hypoxemia, and they're having respiratory distress and assert some catecholamine release because of that, and their blood pressure is high, in which case then you don't want to be dropping their blood pressure quickly with IV medications. So it can be tough to tease that out. So back to our case, he's otherwise kind of pertinent review of systems things. He's not having any visual changes, headaches, any other neurological symptoms, no chest pain, other GI or GU symptoms. And on his first past interview, he denied any substance use, but he did admit to using recreational cocaine, but not on a daily basis. When he went back and kind of talked about the importance of sharing that with us. So I'll give you his other history. We talked about he doesn't really have any other chronic medical problems other than had some attempted prescriptions for high blood pressure in the past, no major surgeries. Apparently, he says several members of his family have high blood pressure, but he doesn't really know the details as to which ones. Are they on multiple medications? How old were they? And he denies tobacco or alcohol. It sounds like the cocaine and marijuana maybe a couple times a week, but he denies everyday use. There's no occupational exposures, no exotic travel history. And give you his exam, and then probably turn it back over after that. So his blood pressure is 204 over 130. His heart rate is 98. Respiratory rate is 18, or approximately 18, and he's saturating 92% on room air. He's not in any acute distress, so he's just kind of sitting in the stretcher bed. He's calm. He looks relaxed. HE&T exam is normal. His heart is regular. He's slightly tachycardic. He doesn't have any lower extremity edema or obvious JVP. Gave the honest best of a fundoscopic exam. You can see you get a partial view. There's no obvious edema, but so you're not confident in making the call that there's no papilledema with a non-dilated exam. There's no focal neurological deficits. His abdomen is non-tender. And next I've got the labs. Did you want to discuss the exam or give you a little bit more information?
I think we can wait, John, and then we can get the labs. Thank you. Yeah. So friends, if we wanted to summarize that, we have a middle-aged gentleman who came in for a routine screening of high blood pressure. And from the information we have so far, there was no concern for any acute end organ damage. The person just has pertinent history of few weeks of non-productive cough. And the important history we got later was that person uses cocaine intermittently, and there are multiple family members who have high blood pressure. So how would you approach this scenario? Now, often this is also very common that when you go and talk to somebody and you ask them about family history, they will say that, yeah, you know what, doc, I have got one of the cousins who had high blood pressure, or I had one of the friends who had high blood pressure. So the question becomes that when does the family history become significant? Because if you just put all your money on this being familial hypertension, then it is possible that you might have an anchoring bias and you might close the workup ahead of time. So in this scenario, the first things we have to ask is, did any of the family member suffer from a complication? So in fact, most of the people who have so-called familial hypertension, they also have early onset strokes. They also have early onset MI. They also have early onset CKD. So these are the things we would be important to know, that do they only have hypertension or do they also have end organ damage? The second variable is what's the age. Now, if they tell me that, oh, you know what, my dad died of the heart attack from hypertension at the age of 75, then probably that's different than saying that, oh, I have a sister who had a stroke at the age of 25 and now is paralyzed and cannot walk, right? So you want to know that what kind of relatives we are talking about, what's the age at which things happen, and what was the gravity of the complication which happened. So once we are able to tease out all these details, and let's say if we for sure can say with certainty that, hey, this is real familial hypertension with end organ complications, then we can start exploring the genetic causes of hypertension. Second thing, that what else can be driving this? So what are the big buckets when we are looking at the hypertension? So first one, most common we talked is essential hypertension, in which we say that it's polygenic. So it depends on multiple genes that you inherit based on your environment, based on your diet, based on your upbringing, based on your environment, and you can have hypertension, which is the common one. But what are the other big buckets that you should look for? So as Dr. Singh was telling earlier, endocrine bucket is the big one. So we would also want to know if there is any family history of thyroid disorders, of adrenal disorders. Those are the big things. Second, substance abuse. So now we know the person uses the cocaine intermittently, but still maybe after we build the rapport with the patient, it's a wise idea to go again and ask them that how frequent you're talking about. And apart from cocaine, is there anything else? Like, are they using marijuana? Are they using nitrous oxide? Like any kind of substances, we want to have absolute clarification of what's going on. Third thing would be that is it possible that person is taking some over-the-counter medications like cough syrups, like anything once in a while which could be causing this? Like, are they taking any herbal supplements which can have some substances which could cause hypertension? So because people don't consider herbal supplements as meds sometimes. So you want to ask them that, tell me everything that you take apart from the food which you eat on a daily basis. Tell me literally everything. So you got to be clear so that you don't miss any subtle clues there. The other thing could be that the kidney dysfunction, because what happens is as soon as you start hearing about family history of hypertension, you will start wondering, oh, is this one of those rare mutations in the aldosterone pathway? But then you forgot the part which Dr. Singh was highlighting earlier, that there are so many kidney diseases which are familiar. So for example, it's not uncommon for people to have autosomal dominant polycystic kidney disease coming in at the first time with hypertension. They won't present with kidney symptoms. They won't present with hematuria. All they will say is that multiple family members had hypertension and you could miss the kidney pathologies. So that's why it's very important to figure out that which organs are involved and what's the story. Now, let's say for the sake of easiness and the fact that this is a VMR bias, John is presenting the case to us, then maybe it is indeed familial hypertension, let's say. And then we go down this big rabbit hole that what are the big excesses that we are looking for. So whenever somebody has familial hypertension, common things being common, first we want to know how is the renal parenchyma doing? Like if anything is wrong with the structure of renal parenchyma. So does the person have cyst in there? So ADPKD, ARPKD are some of the common diseases, but then there are other rare diseases like medullary cystic kidney disease, medullary sponge kidneys, so on and so forth. Second is there anything wrong with the glomerular basement membrane? Because there are so many congenital causes of nephritic syndrome and nephrotic syndrome, all of which will eventually manifest with hypertension, strokes, and everything. So we want to know that was there any history of like swelling in the legs, any history of blood in the urine? So we are looking at the familial glomerular disorders. Then we come to the pre-renal vasculature. Like some people can have familial FMD, familial renal artery stenosis, familial aortic pathologies, which can cause this. So that's what we want to know. Once we have solved the puzzle of the macro things of the kidney, then we go to the micro things, that what could be the genes which could be causing this. So that's the endocrine part which Dr. Singh was talking about, that the big hormones which control our blood pressure are aldosterone and cortisol in some conditions. So we want to know that is there any defect in the cortisol pathway? Like people can have, let's say, 11 beta hydroxylase deficiency. People can have 17 alpha hydroxylase deficiency. And then the reason why I was bringing the supplements, because we know that licorice can inhibit the 3 beta hydroxysteroid dehydrogenase type 2 enzyme, and which can also cause hypertension. And then there are other rare things like what if there is problem at the level of aldosterone receptor itself, that maybe there is constitutive activation of aldosterone receptor. And as you know that in the distal convoluted tubules, when aldosterone acts, you also have epithelial sodium channels. So what if maybe aldosterone receptor is fine, but there is mutation in the sodium channels which are absorbing the sodium, so that will be the Liddle syndrome. So this way you have the whole axis to explore, starting from the renal vasculature all the way down to the renal tubules and the genes involved. So what will be the next step in this case? So as I said, we'll go back to the bedside, get the detailed history of the over-the-counter medications and family history. And second biggest step would be getting the POCUS, making sure heart is doing fine, getting the BMP, making sure the kidneys are fine, getting the urine sediment, and then we can explore further. What do you think, Dr. Singh? How can we?
It's amazing. You wouldn't think you could squeeze so much out of a case with hypertension if you think about it, but it's so important. You know, the first Alec thought, oh, high blood pressure. Oh, that's straightforward. Treat the high blood pressure and be done with it. but there's just so much, like you said, if you perform premature closure, you might miss something more nefarious that's behind the curtain. And some of those secondary causes can definitely be, that could be a play. You have the cocaine use, and that is something we could anchor on very easily. And we see quite a bit of that, but we see many patients come in with these modifiable risk factors or these causes, but there's always something maybe behind the curtain, and it will be devastating not to be able to pick up on that and then miss that with a patient that will be discharged early, thinking it's cocaine-induced hypertension. But I think, yeah, for management reasoning, definitely get that the EKG POCUS is good. Sometimes we get an echo to look at the heart, the structural changes in the heart due to long-standing high blood pressure. I think it's early to do any endocrinological testing. You could do TSH at this point, maybe. I think it's kind of early, but I would just start, UA, CBC chemistry. We didn't hear about any hematuria, but I'm wondering, we've had numerous cases of nephritic syndrome, and that can manifest with AKI as well. So we'll send it back to John for the labs.
Okay. Yeah, so as far as the additional family history, sounds like he wasn't in close contact with a lot of his family. So there was like somebody with some type of heart disease, some type of heart disease, but wasn't aware of heart attacks or strokes specifically. So next bit of data is labs. White blood cell count is 10.7. Hemoglobin is 10.3. Platelets are 141. MCV 75.7. And chemistries. His sodium is normal. Bicarbs 25. Potassium is 3.4. BUN 29. Creatinine 3.09. So total billy is 1.6. AST, ALT, alk-phos are normal. And in the first box, we also had a pro-BNP of 6,757, and the high sensitivity troponin initially 68 and is 61 on a repeat somewhere between 1 to 2 hours later. And of course, that creatinine, look back in our EMRs, function to talk to other institutions and see that there's some creatinine of around, range between 1.5 and 2 from some old emergency room visits, but a couple of years ago. So we don't really have a recent baseline value or know what the circumstances were when that creatinine was checked before. So not really a reliable baseline to compare that to. He had ECG, shows sinus tachycardia as well as signs of left ventricular hypertrophy. And I think they went right to a CT of the chest instead of just kind of skipped an X-ray went right to the CT scanner. They got it without contrast because of the kidney function. And I can probably just in some time I'll kind of share the read with you. Described as severe bronchial wall thickening, moderate pulmonary edema with interlobular septal thickening, patchy right lower lobe ground glass opacities, and small bilateral pleural effusions. So kind of summarizing for describing the severe bronchial wall thickening, pulmonary edema, right lower lobe ground glass, and small effusions. So he was still in the emergency department at this point. He is given a dose of IV hydralazine, and his blood pressures come down to 180 systolic. And we have, you're the hospitalist, you are called to admit the patient to the floor. So I'd like to kind of turn it back to you, and what are anything jumping out to you in those labs and first pass evaluation, and maybe talk to us about how you're thinking about triaging this patient.
Yeah, two things. I think we're in Didn't we explore the space of pulmonary renal syndromes before? It was interesting. The symptom earlier on was very non-specific. It was the cough, right? The cough could be anything. You did a very nice 2 weeks ago, I think it was a week ago, talking about J receptors in heart failure and that causing cough. But in this, the ground glass can spell many different things. It can be if it's bilateral pulmonary edema, but then you can have other things. Could this be autoimmune phenomena? Could this be a vasculitis? And we don't have the UA yet. So the UA is going to be invaluable. I think it was JAS. Yeah, we discussed it. I discussed a case with JAS, which was GPA in this case. But before we even jump on the vasculitis bandwagon, two things that I sort of want to bring to everybody's attention with malignant hypertension, hypertensive emergency. It has the propensity to cause such shear stress on the endothelium that it can release tissue factors and actually cause a malignant, what do you call it, hemolytic anemia, and also a DIC that can happen. So massive thrombosis just from endothelial exposure and damage, and then the shear stress can also cause microangiopathic hemolytic anemia. Other thing that just sort of jumped to mind was TTP. Is this maybe TTP kidney failure, the high blood pressure, and so on? There's no fever, no altered mental status, but I've seen patients with probably only 3 of those of that pentad, the traditional pentad which we teach. But the platelets are usually really low in that case, less than 30,000. But here we have slightly low at 141. So at this point, I don't think we're dealing with TTP, but I would keep it on the back burner because in a day or two, the platelets could tank and we could be then moving into the domain possibly of a TTP-like process. But yeah, with these lungs, I'm very suspicious of maybe autoimmune phenomena. Definitely will be useful to explore maybe getting anchors at this point. But before that, the urine. I'm really interested to see what compromises the urine before I, the chicken or the egg and order the anchors. But I really like what you did. You went back to see what is the baseline. Say the creatinine was 3 before, so then we don't really have to explore this space and do a lot of cognitive legwork. But there definitely has been a deviation from the baseline, and this is part of the process. Could this be just malignant hypertension or hypertensive emergency? It can. So bringing the blood pressure down is imperative. But now with these pulmonary symptoms and these pulmonary findings, I'm definitely very suspicious of maybe autoimmune phenomena. Infection, less likely at this point. There's nothing here that you sort of, no signature of an infection, no immunocompromise. What if you said this patient was a renal transplant patient? This patient was an oncology patient receiving immunotherapy. This patient has HIV, lymphoma, or something like that. We don't have that to contend with. So at this point, I'm going to be more along the structural autoimmune phenomena inflammation bucket at this point. What do you think, Kirtan?
Perfect. Thank you, Dr. Singh. I enjoy how you highlighted the lung findings, and it is very important actually. So from the data which John has given us, we can say that there is septal thickening, like interlobular septal thickening, bronchial wall thickening, some bilateral effusions, and probably some GGOs, right? So the most common things in such scenario would be that maybe given the BNP and troponin, which is high, maybe the heart is not able to keep up, like what we were saying initially. Maybe this is CAPE kind of stuff, which is why things are dampening up, and this is just pulmonary edema, which can cause septal thickening. And the alternate possibility, what Dr. Singh said, is what if those opacities indeed represent blood and it is diffuse alveolar hemorrhage, and then we are dealing with pulmonary renal syndromes, and that's why UA is going to be really important. But now the only issue is that usually in people who have pulmonary renal syndrome, they don't tend to have profound bronchial thickening and septal thickening, but it is not unusual to have atypical presentation. So definitely getting the serologies regarding that pulmonary renal syndromes is important, and we'll talk about that later. The reason why we wanted the echo, the reason why we wanted the EKG was to assess the baseline organ damage. So given the fact that this person has hypertrophy, so as we predicted earlier, this is a slam dunk that this person doesn't have hypertension which started yesterday. It's not like he took cocaine yesterday and now he had this. This person definitely had hypertension for a quite while now. That's why there is hypertrophy of the left ventricle. Same thing is true for the kidneys, that since we don't know if this is the patient's baseline or not, it's easy to assume that maybe this person has some degree of CKD, and maybe what we are seeing is AKI on CKD. And of course, getting the renal ultrasound is going to be key to figure out if the kidneys are small, suggesting of like CKD, or is it kidneys are looking fine and maybe it's not CKD. So having established the fact that this person does have some end organ damage from hypertension, now we can be a little bit more confident that we are dealing with a syndrome which has a familial predisposition, which is causing hypertension at such a young age, and which is also affecting the kidneys. Now, the chicken and egg problem that we talked about, that is it just that patient has long-standing hypertension and which caused the CKD, and now the CKD is worsening and causing this, or is it other way around? That maybe the problem began with the kidneys itself. Maybe there was some channelopathies or some parenchymal damage which caused the hypertension in the first place. And are there any subtle clues that we can glean at? So the patient's potassium was 3.4 and bicarb was 25. Now, they always say in medicine, that like, don't just jump to the labs, look at the whole picture and everything. So in this case, of course, I won't put all my money on figuring out that why this person has low potassium and alkalosis. But let's say if we obtain the serial studies, like patient will be admitted and for 3 or 4 days, you see that potassium is on the lower side and the patient's bicarb is like hanging around at 25, then why it is important? Because this person has AKI versus CKD going on. So you could imagine that if somebody has kidney issues, you tend to deal with hyperkalemia and you tend to deal with acidosis. Even if it's AKI, you will still have acidosis of some sort. So you could imagine that if you are in this paradoxical situation, that if somebody has hypokalemia and slightly high bicarbonate, despite having AKI or CKD, you start wondering that could that tell me a clue or not? And that can give you a clue, because as we were discussing earlier, that all the axis of like aldosterone, cortisol, and metanephrines exert their effect through this pathway. That whenever there is activation of aldosterone and cortisol, you will end up dumping the potassium in the urine, and that's why you will become hypokalemic, and you will also be alkalotic at the same time. And since there is family history, I would be more curious to know that what does it imply. So if the potassium and bicarb remains like this, then I would like to get the renin activity, aldosterone level, random cortisol levels, and even the metanephrines to make sure that I'm not missing any familial cause of channelopathies or endocrine axis which can explain this. The second part which I'm going to focus on is what Dr. Singh highlighted, that could this be pulmonary renal syndrome? Absolutely. Maybe this person's family history of hypertension and everything, maybe it's not relevant. Maybe it's just like red herring. We are not sure about the age. John told us that person is not in close touch with them. So we don't want to anchor just on this fancy genetic stuff. We want to explore the common realm as well. So what Dr. Singh was telling is RPGN, which stands for rapidly progressive glomerulonephritis. So what happens is, because of certain diseases, your glomeruli are just choked down to the extent that you can't excrete anything and all the volume dams up. And you can also simultaneously affect the pulmonary capillaries and cause all these lung findings. So important serologies to obtain would be ANA for lupus, ANCA for ANCA-associated vasculitis, GBM antibodies for Goodpasture syndrome and basement membrane disease. And down the line, if other findings come up, then we can even get the cryoglobulins. And sometimes IgA vasculitis is also very rare. But again, based on UA, we can figure out if it is IgA vasculitis or not. Apart from US renal, is there something else that we can do? Then I guess we should also get ultrasound duplex of the kidneys to make sure the renal arteries are well. Now, resolution of the ultrasound may not be the best, and you might need to do CT angio down the line. But with the kidney dysfunction like this, maybe giving contrast is not the best idea. So I think we can start with this thing. Get the endocrine workup, like renin aldosterone stuff, get the UA, spin the urine, get the ultrasound duplex, and then based on those studies, we can proceed ahead. So yeah, we can get more. Yeah, Dr. Singh, any ideas?
Yeah, I just want to add, the renal ultrasound is important because many times I've had cases like this that it could be post-renal, a renal obstruction as well. So just make sure you don't have, in this patient, BPH kind of would be early, but we do see it. We do see enlarged bladder. Post-renal isn't respected as much as like pre-renal, intrarenal. So that would be an invaluable resource or test to get to rule that out. Once you ruled out post-renal, then we can go back to the drawing board. But getting the urine is going to be very important at this point. Back to you, John.
Cool. So with the labs coming back, I see the kind of the anemia, thrombocytopenia, little elevation of the total bilirubin, catch my attention a little bit, in addition to this tension with the lungs and the kidneys, thinking about the possibility of a pulmonary renal syndrome. So I pushed back a little bit on the request to admit to the floor. I asked cardiology to come down and see. The fellow comes down and does an echocardiogram and shows a left ventricular ejection fraction estimated around 40 to 44%, along with grade 3 diastolic dysfunction, with concern, suggestive of restrictive physiology, a small pericardial effusion with no echocardiographic evidence of tamponade. And when I take the call, I also ask the lab, will you add on a LDH and a haptoglobin to those labs they already drew? The LDH is 450 and haptoglobin is undetectable. So the cardiology team accepts the patient to the cardiac ICU. They place an arterial line, start an IV infusion of clofidipine to try to quickly control the blood pressure. So I'll give you some more of the labs here. So get some further, next set of blood work includes urine. This urinalysis, 1+ blood, 2+ protein. Urine drug screen is positive for cocaine metabolites. Is vitamin B12 level is 310. Folate is 10.0. Got his iron's 44, ferritin 443. His TSAT is 13%. Fibrinogen is 468. INR 1.2. His urine protein is 340 milligrams per gram of creatinine. And he does get some autoimmune serologies, and this next set of labs that are drawn kind of early the next morning. His complement levels are normal, hepatitis B and C negative. The ANA is 1 to 40 in a homogeneous pattern. The ANCA serologies are negative. We tested for Adams TS13 activity. That was normal at 82%. And I think probably the next test, didn't want to reveal the diagnosis. That next one probably reveal the diagnosis. So let me see what else I have, and then I'll turn it back to you to discuss this, and then I'll kind of share our the resolution of the case and what we the rest of his hospital course.
Perfect. So maybe I can tackle the first half and then I can give Dr. Singh the rest. So this is very important. Remember, like how we were discussing earlier on, that it's very important to take the history. Like, okay, person is using the cocaine intermittently, but we did say that I do want to go back to the patient and ask that, what do you mean by frequently? Like how frequently you are using it, right? So in this case, we did find that the person does have some cocaine in the urine. So at least, even if person didn't use it every single day for last 2 or 3 months, at least he did use it for last few days. So which is an important clue. The second thing is, remember how we were saying that we are not going to get anchored in this family history and then miss the whole train, right? So that is what Dr. Singh was telling us, that you need to think about pulmonary renal stuff. You need to think about the glomerular pathologies. And that is what looks like is going on, because in this case, we have slam dunk evidence of hemolysis. There is no cirrhosis which can cause falsely low haptoglobin. You have high LDH, you have high indirect bilirubin. So everything is pointing towards the so-called thrombotic microangiopathies. And I'm sure that if we do the serial evaluation in this person, then eventually the platelets will dip down at least a little bit, if not like severe thrombocytopenia. So the question becomes that when we are dealing with a syndrome of this thrombotic microangiopathies, which is affecting your kidneys, what are the key features which should help you move ahead? So first thing is differentiating between TMA and DIC. In this case, given that coags are looking fine, we will be assured that this is TMA. Once you are in TMA realm, you start looking at the common things and then you move to the next step. So first thing, TTP, life-threatening, you need to give plaques. John told us that ADMTS 13 levels were like normal, and it is a very sensitive thing. So we will trust that the lab is like true positive. So we will forget about TTP. The second things become, could this be drug-induced thrombotic microangiopathy? So there are so many drugs which can cause TMA, but one of the big ones is the recreational drugs. So things like heroin, fentanyl, opioids, oxycodone, cocaine, amphetamines, and even the things which are mixed with cocaine like levamisole, and all of them are known to cause thrombotic microangiopathy. So John told us that there are some metabolites found in the urine. Now, I'm not sure. Like, does that mean that person did have levamisole or not? And although in our mind we think that levamisole will always cause ANCA vasculitis, that's like not very strong association. People can have ANCA negative effects of cocaine and levamisole on their kidneys and microvasculature. So drug-induced thrombotic microangiopathy is something which will be a strong consideration. Second big entity is, could this be complement-mediated microangiopathy, the prior known as hemolytic uremic syndrome? Now, that's why it's very important. John told us that complement levels were normal. Now, in people who have complement-mediated TMA, you expect complements to be down, usually. There are some rare mutations which can cause normal complements and TMA, but that is very rare. So we would say that maybe it's not complement-mediated TMA. Then what about complements? So if it's lupus causing this, then complements should be low. Complements are fine. Cryoglobulins, complements should be low. So that is also out. ANCA, could this still be ANCA? It could be, because we know that ANCA is not as sensitive. Like you could have seronegative ANCA as well. So kidney biopsy down the line will be important if we are going down that path. Second big autoimmune bucket includes antiphospholipid antibodies and scleroderma. And sometimes scleroderma can be missed. So of course, I would like to go back to the patient's bedside, would like to examine their skin, making sure I'm not missing any subtle signs of scleroderma, and it will present with normal complements as well. So scleroderma APLS is the next big bucket. Down the line, if this person has sickle cell anemia, doesn't look like it from the hemoglobin, so that is also out of the picture. What else can we do? Now, is it possible that this person has IgA vasculitis? Because sometimes IgA vasculitis is also known to trigger the thrombotic microangiopathies. So that will be important to know. Further down the line, could this be systemic embolic processes like endocarditis causing TMA and endocarditis causing glomerulonephritis? This person is a drug user, but so far, no fever, echocardiogram didn't show any vegetation. So the concern for endocarditis is also low. So where are we standing right now? Our tension is this complement-mediated TMA? Is this drug-induced TMA? Or is this one of those rare autoimmune causes of TMA? So that will be our first pass. And I'm curious to hear from Dr. Singh that how would he approach this situation?
Wow, incredible sort of the picture you painted of PMAs there. There's just one thing I just want to add to this. What if it's just the blood pressure? We earlier on had hypothesized that hypertensive emergency can cause the kidney failure, can cause the cardiac issues. This could be pulmonary edema, like you said, Scape, and it can cause microangiopathic hemolytic anemia. Just that severe stress of the blood pressure on the endothelium, and then you could just imagine it just rolling over the RBCs and at different branch points in the vessels, hemolyzing the RBCs. So I'm kind of trying to understand this patient. Is this patient devastatingly ill? What do you think, Ethan? Like this patient, definitely I applaud John for not taking this patient onto a regular floor. Sometimes the emergency room will say, it's just blood pressure, patient does not need a monitor, but he astutely identified there's something more going on, and we should put this patient at a high level of care. So that's very important, because patients like this on a regular floor, unmonitored, can be at risk for adverse events. So, but is this patient looking very toxic or in distress?
Yeah, I would say, Dr. Singh, that it is very toxic looking. And the reason being that when your kidneys are short, you know that kidneys are going to make everything worse, right? So yeah, I do agree with you that I would consider this patient as kind of like sick patient.
Yeah, it's interesting. The general is calm and relaxed patient, right? So I wonder, like 4 hours later, maybe not. So if John has labs afterwards that portray maybe the patient declining, yes, that could be interesting. But at this time, calm, relaxed, his breathing, respiratory rate's 18, not tachypneic. I mean, tachypnea would be a major signal there. The blood pressure is high, but there's not much else that I see. So this is something odd. Even with so much lung pathology, the patient is not having major hypoxemia, tachypnea, and so on. Or maybe they're young enough they're compensating. But it's sort of interesting if you see that the patient is calm and relaxed. Meanwhile, you see all of this that's internalizing within the patient. But anyway, back to you, John. What, or is there one last aliquot before the final diagnosis?
Well, I think this will probably give the final diagnosis away. So, but I think you've really amongst the discussion, you've kind of both of you kind of nailed what's going on. So what happened? Like his blood pressure gets controlled in the ICU, but if times go by and he gets some some more blood work and took a look at the urine again, his inflammatory markers are unremarkable. New sample of urine, the sediment is not really suggestive of a glomerulonephritis. He had some other testing, including like anti-GBM, is negative. So I was really kind of like thinking I was going to be diagnosing an exotic like pulmonary renal syndrome, but didn't really turn out that way. So he had other testing included renin and aldosterone, which was actually, as with the hypokalemia, I was also really pointing towards that. These were actually, the renin was 3.5, the aldo was 9 point something. Not really, overall, not a slam dunk for a hyper aldo. And he ended up with some more time with blood pressure control, the kidney function came back down to around 2 and plateaued there. And he got a renal ultrasound. There's no obvious signs of renal artery stenosis. And repeated those markers of hemolysis, and those actually normalized as well with 24 36 hours of good blood pressure control. Question in the chat, like the urine protein creatinine, it was and he just had a spot. He didn't have 24-hour urine, but it was somewhere around 350 milligrams per gram. So ultimately, the way we put this together was we'll never know for sure whether it was the cocaine or the high blood pressure that caused endothelial damage, leading to microthrombi formation, leading to hemolysis as your blood goes through those vessels, or thrombomicroangiopathy. But with control of the blood pressure and not having cocaine, the syndrome resolved. So it could have been either one of those as the culprit, and there's not really any way to know for sure. But this thorough workup looking for the pulmonary renal syndrome that I was kind of sure that evening I was going to be diagnosing, but no, more common things like the TMA isn't the most common bread and butter for amongst the hypertensive emergencies, but he really had he had a hypertensive emergency with heart failure and TMA. With I'm sure the cocaine was likely contributing to the cardiomyopathy as well. I think heart failure was also multifactorial.
Wow, incredible! Definitely, we do see this, but I'm just wondering: does he have pre-existing high blood pressure that was just aggravated by the cocaine? You would say?
Yeah, that's what I think he's had. Especially with the LVH on the echocardiogram, I think he's had untreated hypertension for a long time, and then just had with the surge of catecholamines from the cocaine, it tipped him over to the point where he had endothelial damage and heart failure, and ended up kind of luckily having a pre-employment physical to catch these things and get him plugged in with care.
Oh wow!
Okay.
Here's the
Good.
hypertensive emergency, devastating.
Right.
Yeah,
Good.
yeah.
And maybe, I just wanted to ask one clarifying question, John, that you said all the labs eventually normalized. So like when the person was out of this clinical course, did the potassium and bicarbonate also like completely normalize, or they were still a little bit hanging on the lower side?
Yeah, the bicarb was in like the mid-20s, and the potassium was in the lower range of normal. Like 3 point, between 3.5 and 4. So he ends up gets placed on carvedilol, fetapine, and he was discharged on hydralazine as well, which I don't know, probably would not have been my favorite choice of a medicine because it's so frequent. It's you have to take it several times a day. There's all these, there's drug all kinds of complications that can come from it. And there's like data now showing that things like the chlorthalidone can be used in up to stage 4 chronic kidney disease and still be efficacious. And spironolactone, especially since he's not really having dangerous high potassiums. Potassium's in the lower side of normal, so perhaps spironolactone might have been a choice I would have gone with instead. But come back to earlier question, like whether there's a component of familial hypertension. He's pretty young, and I don't want to chalk all this up to the sporadic cocaine use too. So I retain suspicion for a familial hypertension syndrome that was exacerbated by cocaine, leading to hypertensive emergency with heart failure and TMA.
Yes, so some great management reasoning. I think Yusuf will be proud. But yeah, chlorthalidone is an amazing drug and much more preferred over HCTZ. And you're right. Usually they would state Lasix up to a certain stage of CKD because chlorthalidone won't be as effective. But I think you're right. Like up to stage 4, it can be very potent in this case. So yeah, ACE/ARB, calcium channel blocker. I found Procardia to be more useful just because you can dial up the different doses. Amlodipine, just for that 10, 15 millimeter drop, you need 5 to 10 milligrams, but Procardia really does a good job. In the old days, short-acting Procardia used to be given, which is very dangerous in the emergency room. So you have a patient coming in with uncontrolled hypertension, short-acting Procardia used to be given to the patients, get their blood pressure down. That way you don't have to send them to the intensive care unit or ICU step down. But what that did, it would result in myocardial ischemia, infarction in patients. So they stopped. If you're wondering why don't we give Procardia short-acting, that was the reason why. So we no longer have doing that anymore. So long-acting Procardia is something that I use often in these patients. Kirtan, any final words?
Yeah, thank you. Firstly, I wanted to thank Dr. Black for bringing a wonderful case. It's like bread and butter, but rare at the same time. And I just wanted to, kind of recapitulate the journey that we started with the high blood pressure. And we said that, okay, maybe the clues is in the family, in the substance abuse. And we found the hints of both of them. And then fortunately, with Dr. Singh's wisdom, we are not going to anchor on either of them. We were considering both the possibilities at the same time. That is this drug, is this familial or not? Then we went down this rabbit hole of thrombotic microangiopathy. And again, we were making sure that we are not going down all the rare causes, and Dr. Singh reminded us that hypertension itself can cause all of this. And then at the end, we again come to the first question itself, that what started all of this process? Because if we believe that all the family members had this, and with those potassium and bicarbonate playing the trick, you do wonder if there was a familial component as well. And I agree with John that despite the normal renin aldosterone level, it doesn't mean that you have no, like for example, people can have something known as glucocorticoid remediable hyperaldosteronism, which can present with normal renin aldosterone, but still you can have hypertension. And the only way to find this is by doing the genetic screening for those particular genes. So in this case, down the line, it would be interesting or kind of like fascinating to know if we do the genetic screening, then what do we find? So very humbling case, very nice case. And thank you, Dr. Singh, again for discussing with me. It was nice. Thanks to Patricia for helping with the scribe. And maybe I will pass back to Kushal for telling us the teaching points. Thank you.
Before that, thank you, Kirtan. Such wonderful teaching. So many different things were brought up. It was just amazing. I have to go back and read each and one of those pearls that you shared with us. Back to Kushal. Thank you.
Hey, hi everyone. So it's an amazing case and super discussion, and I'm not quite sure if I've done full justice in terms of capturing all the teaching pearls in the teaching points, and I would highly encourage you to all listen to it again. So one thing which I'm going to just go with 3 important points which I learned it today. And first one was how it's important to manage the patient at the same time go with the diagnosis. So immediate thing is when the patient is presenting with 204/130 is to manage the patient in terms of stabilizing them, as well as taking good history to see if it is actually primary hypertension or a secondary hypertension, and also to do a good physical examination and what are the labs you're going to do initially and what are the labs you're going to follow it up with. And the other thing which I learned was about acute flash pulmonary edema, which is also known as CAPE. And the other important, interesting point which I learned was the fentanyl, heroin, levimazole drugs could be causing the hypertension, and also that they cause ANCA negative vasculitis.
Thank you, Kuchal. That was amazing. You touched on all the really important points. There's so many, but you caught the most important ones. All right. Thank you, everybody. Thanks again, Kirtan. Thanks, John. Amazing case, especially 8 p.m. on the East Coast. It's 5 p.m. West Coast. Everybody have a great evening. Take care.